have it on SAS Blood. So thank you so much, ladies. Stephanie and Melissa are our true nurse navigators for the IG Stewardship Program in Saskatchewan. And I see Dr. Harding's here, and Dr. Harding is our lead clinician for the IG Stewardship Program. So if you have any questions, we should be able to answer them today. So I will mute myself.
Hi, thanks, Paula. Yeah, my name is Stephanie Jensen. As Paula said, I am the nurse navigator in South Saskatchewan. My partner up there is Melissa Green. She is the nurse navigator in North Saskatchewan. The North and South designations don't mean a whole lot. We do cover the whole province. We just share one position full time. So I work Monday, Tuesdays, and Wednesdays. Melissa works Wednesday, Thursdays, and Fridays. So whenever you call, you'll get one of us, and we'll be happy to help you. So our presentation today, we're going to go through a program overview. We're going to go through the adult order set, which is very similar to the current pediatric order set. And then we're going to go through reporting of adverse reactions. So first, we'll start with an SHA Treaty Land Acknowledgement. We acknowledge that we're gathering on Treaty 2, 4, 6, 8, and 10 territory and the homeland of the Dakota, Lakota, and Métis. Recognizing the tree is important to our future and our efforts to close the gap in health outcomes between Indigenous and non-Indigenous peoples by knowing what the land and the traditional people of the land offer us. So a bit more of what our goals are for today. We're going to define immune globulins, explain the rationale for the development of our program, describe what Melissa and I do on a daily basis as nurse navigators, clarify the screening and approval processes that we use for outpatient and that lab will use for inpatient order sets. And then Melissa will end the presentation with describing some common adverse events associated with IVIG infusions and the process of reporting those said adverse events. So to start, what are immune globulins? The immune globulin is a fractionated blood product derived from the pooled plasma of thousands of donors and can contain thousands of different antibodies. There are two main categories in which patients fall into when they're receiving immune globulins. They're either immunodeficient. So in those cases, the IG provides a boost of antibodies and helps those people fight infections, or they're receiving it for immunomodulatory conditions. In that case, it impedes the progress of an autoimmune disorder through anti-inflammatory mechanisms. There are three ways that IG can be administered. The most common and what we typically see here is intravenous. So typically those doses are given as a one-time induction doses, or in some circumstances are given over a maintenance schedule of weekly to monthly. Those are usually given in either the inpatient hospital setting or outpatient infusion clinics. And doses for these can range anywhere from 0.2 all the way up to 2 grams per kilogram, depending on the indication for use. Subcutaneous IG is a little bit different. It's still the same immune globulin idea. However, this is given once to twice weekly. The doses are quite a bit smaller. As you can see, they range typically from 0.1 to 0.4 grams per kilogram. And subcutaneous IG can actually be administered in a patient's own home by the patient themselves or any family or friends that are willing to help. The nice thing about subcutaneous IG is it tends to give people a little bit more steady state in their IG levels. IVIG tends to give you a nice peak at its effectiveness, and then it kind of troughs off before the next dose, where subcutaneous typically gives you a little bit more of a steady state. Currently, we don't, as the nurse navigators and the IG stewardship program, we don't have a role in screening and approving subcutaneous IG orders at this moment. That's going to change with the launch of a new POS. We don't have a date for it yet, but as of right now, our role mainly is for education as far as subcutaneous IG. And the last way IG can be given is intramuscular. We don't see it typically. It's not very common, and it tends to be specific for a one-time dose for a very specific indication, used for short-term prevention of specific infectious diseases. It will be used for measles in the event that there's any kind of measles outbreak or exposure, but typically we won't see that quite very often. So why was the program created? In 2020, Canadian Blood Services identified that there was a possible disruption to the IG supply worldwide, not just in Canada, but worldwide, there was possibly going to be a decrease in IG supply. So they released some recommendations to prepare for that shortage. So what they said was that we need to start working toward ensuring that the utilization of IG products follows best practice and provincial territorial guidelines, and that dose calculation of adjusted body weight doses should be used for adult patients. We're going to go into adjusted body weight calculations in a few slides. But what we did find that is that demand for IG was continuing to increase steadily in Canada from about 6 to 10% per year, and globally around the world. Canada is actually the second highest global user of IG per capita. And due to the usage of IG in Canada, we were such a high user. There was a number of audits that performed to understand the utilization of that product. And it showed actually that a lot of the IV was being given for indications outside established criteria and guidelines. So in that respect, that's why we were created. So the IG Stewardship Program was created to assist in overseeing the establishment of some of these recommendations. Our goal is not to limit the use of IVIG or to prevent people from accessing IVIG. Our goal is to make sure that we're using it appropriately. So we're screening patients for and making sure that they're on the most effective, efficient, and clinically appropriate dose of IVIG. So our program recently just celebrated its 2-year birthday. It was launched in November of 2021. So up to today, some work that we've done is we have the adult 10% IVIG practitioner order set, which I said we'll go through over the next couple of slides. That order set is currently under revision. If you have any feedback on what you like, dislike, or want to see on a new order set, please reach out to us and we can take that into consideration. Like I said, we're just working on it right now. So right now is the perfect time to get any feedback in. The pediatric 10% IVIG order set launched in June of this year and looks very, very similar to the current 10% order set. We developed a province-wide patient and physician registry. Prior to the initiation of this program, there was no overarching registry of who was giving IVIG for what indication and when and where. So we've developed a registry for that. We are currently, as I said, developing a 10% IVIG measles POS. It's only going to be used for emergency medicine in the event that there is measles outbreak. So hopefully you will never see it. We've also developed quite a few educational materials that can be found on sasblood.ca. And Melissa's actually going to take you on a bit of a tour of SAS Blood later on in the presentation as well. So Melissa and I, what do we do on a daily basis? We screen and approve outpatient order sets. So when we receive an order set to our inbox, we clarify that the doses are appropriate. So that's appropriate by indication and appropriate by orders. So if we have any inappropriate order sets that come to us, we will reach out to the prescriber and ask for clarification regarding that. If we have any major concerns, we will consult the transfusion medicine physician on call and ask for their assistance as well. We maintain that patient registry. So as of the end of last month, we've reduced IVIG usage by about 9,070 grams. It's a little bit, I guess that's the information as of late September 2023. So we actually are a little bit above that now, but we have saved a significant amount of product. And not only with saving the product, we also save chair time for patients, chair time for nursing infusions. So there's a lot of nice secondary advantages to saving the product as well. We're also registered in our patient registry. We keep track of blood product consent forms. So as you know, IVIG is a blood product and needs consent yearly. So we are monitoring all of those IVIG consent or product consent forms. This is something that used to fall onto the clinics and the bedside nurses. So we've taken that on for them. We are monitoring treatment schedules for long-term patients. So those are the patients that are on it weekly, monthly going forward. I think we have about 200 in our registry that are long-term users that use it monthly. So we do monitor their treatment schedules. We contact the prescriber with renewal letters to inform them that the order set that they currently have is about to expire. And with that, we hope to prevent any delays or gaps in the care for the patient themselves. Again, that's something that used to fall to the chairside or bedside nursing. So we've taken that on and off their plate as well. We do some education sessions. As you can see currently, we are doing an education session right now. We've done a few others for smaller centers, rural centers recently as well. We do some patient education if and when required. And we do quarterly nursing lab WebEx updates. We did one just in early October, and we will do another one early 2024. Hopefully it will coincide with the launch of the new POS, but we will keep you posted on when we actually have that one scheduled. So we're screening IVIG orders. So what do we look for? This is a page 1 of our order set. Number 1, we look for, there's patient identifiers, name, HSN, and date of birth. We have a 4-page order set, and sometimes it can get a little cumbersome. So we just like to make sure that everything is appropriate. So we make sure we've got those patient identifiers. Next up, we look for practitioner info. So that's their name, specialty, and where we can get a hold of them. IVIG request, whether it's inpatient or outpatient. Anticipated treatment start date is when that first dose is meant to be given, whether it's inpatient or outpatient, and where that infusion is meant to be given. So some of the smaller centers, some of the larger centers, we just like to put in there so we know where this patient is going. Next up, patient clinical information. Vitally important. We need to know the diagnosis or why we're giving the IVIG. We also here, you can see there's a little tiny letter or line there. Previous reaction to IVIG, yes or no. We do like to know if there's been previous reactions to IVIG. That might mean that a patient needs some pre-medications or that their infusion might be a little bit slower than typical. So we need to know that information. There's also a large box down here for alternative treatments that have been required or have been attempted. Some indications, IVIG is the first line treatment. So there aren't necessarily always going to be other options that we've tried. But in some circumstances with some indications, there are a number of other medications or modalities to treat. So that's just something that we like to know as far as the IG stewardship program goes. Yes, perfect. We need to know if things have been tried. The other thing we'd like to point out, you see those beautiful stars. We need physician signatures. And something again, because the POS is 3 pages that have to be signed, that sometimes it gets something that gets missed. So we like to highlight that it does need to in fact be completed. So when I say we're screening the indication or diagnosis, what does that mean? We have this lovely document, Criteria for Clinical Use of Immune Globulin, 2nd edition. So it is a tri-provincial criteria document. Many experts came together to make this document possible. It's from Alberta, Saskatchewan, and Manitoba. There's diagnoses and indications that kind of fall under a bunch of different categories, including hematology, dermatology, immunology, infectious disease, transplant medicine, neurology, rheumatology, and a couple of others that don't fit anywhere, but it is broken up like that. So what information can we get from this document? Whether IVIG is actually recommended for that indication. So it's nicely laid out in green, yellow, and red. So a green indication indicates that there's lots of research out there that says that IVIG is a good treatment modality for that indication. If it's a yellow indication, maybe we don't know. We don't know if it's going to work for some people and not for the next. There's just not enough research to prove one way or another. And a red indication is simply that we should not use IVIG for that indication. It also provides us in this document the dose that it recommends in grams per kilogram, and also the interval and duration of treatment. So how many, every so often, how many weeks, for how long before we reassess. And then any review criteria that the doctor should be looking at, including follow-up blood work or testing that needs to happen. Sorry. So just some quick examples of that. A green indication, stiff person syndrome. So it says simply that we do recommend it. It's recommended for patients with significant functional impairment. The dose you can see there, induction as a one-time dose and or maintenance dosing. So that's those doses that go forward on a schedule. And then some review criteria as to what we're looking for to see if the IVIG is actually effective in that patient. A yellow indication, Kawasaki disease in an adult. So this says we just don't really know. There's insufficient evidence for or against the use of IVIG, and there's insufficient evidence to recommend a dose. So in these circumstances, it is sometimes nice to have that information as we've tried something previous and it didn't work, let's try IVIG. And these indications are sometimes the ones that we discuss with the TMP or the transfusion medicine physician on call, just to see if the indication is appropriate. And these red indications, Epstein-Barr in post-transplant lymphoproliferative disorders, as I can say easily, it just says that we do not use IVIG. So if we were to receive an order set with one of these red indications, we would stop there as nurse navigators. We'd contact our transfusion medicine physician, and then those physicians can call the prescriber and have a discussion about IVIG and if it's appropriate. So back to our order set, page 2, again, up at the top, we make sure that everybody's got a name, a date of birth, and an HSN. This section here at the top, lab investigations and tests. An ABO group is to be drawn prior to initial treatment. So that's one time prior to the first dose. Even if you had it drawn 10 years ago, that's still okay. We just want to have that ABO group on file because certain blood groups, A, B, and AB blood groups, have a little bit increased risk of a IVIG-related hemolysis after receiving IVIG. So if we know that the patient is any non-O blood type, we like to be aware of that just so we can monitor and see if there's going to be any hemolysis going forward. There's some additional blood work there, creatinine, in that IVIG can be very hard in your kidneys. We like to ask for immune globulin trough levels for patients who are immunodeficient, because we want to make sure that the dose this patient is on is actually replacing those doses or those levels that they're not able to have make themselves. Again, that CBC and reticulocyte count if the patient is AB or AB, 7 to 8 days post-infusion, and a platelet count. If patients are receiving IVIG for ITP, we want to monitor their platelet count 24 to 48 hours later to be sure that their platelets have in fact gone up. This next very large section here is for the IVIG dosing weight. I'm going to go into that a bit more on the next slide, so I'm going to just kind of skip over it for a second. We do need the patient's height, weight, and then the adjusted body weight that we calculate on the next slide. The last part on page 2 here is the actual IVIG dose. So again, whether that's an injection dose or a one-time dose or a maintenance schedule. So we like to see here, how many grams per kilogram are you wanting to order? How many grams total is that? And over how many days? We tend to recommend no more than 100 grams per day as a guideline, or 1 gram per kilogram per day. But that's not to say that's a hard and fast rule. There are exceptions to that rule, but it's just something to think about. Right now, as the IVIG orders stand, maintenance orders, or those long-term scheduled maintenance schedules, have a maximum of 6 months duration per order set. We have had some exceptions to up to a year, but we typically are saying right now that we want every patient reviewed every 6 months to be sure that the IVIG is in fact still appropriate for that patient. And again, as you see on the bottom of page 2, with nice stars, we'd like to see that they are signed and dated by the physician. Sometimes it gets missed, and more often than we'd like to see. So back to this adjusted body weight or dosing weight. So the adjusted body weight is a calculated weight based on gender, actual height in centimeters, and actual weight in kilograms for obese or overweight patients. The use of this is supported by the National Advisory Committee and Canadian Blood Services. So what does obese and overweight mean? Essentially anybody that's deemed to be over their ideal body weight for their height and gender. So on our order set, there is actually a link that will pop up this calculator. Here we can enter sex, male or female. It does auto-populate to male, so that's just something we need to be aware of. So if it is a female patient, we just toggle yes or female or male, put their height in centimeters, their weight in kilograms, and hit calculate. So this will give us a couple of different things. This gives us the ideal body weight, which just goes to show that the patient is in fact over their ideal body weight. And then second here, which is circled, the dosing weight. That's the weight that we're actually going to be using to provide the dose for this patient. The second part of this calculator is it will actually allow us to enter in the grams per kilogram we're hoping to order and give us a dose. So we always are rounding doses to the nearest 5 grams, up or down to the nearest 5 grams. This is because, again, we're trying to be appropriate stewards of the product. So if somebody was to order 65.5 grams, we actually do not have 0.5 gram vials. The smallest vials we have are in some products 2.5 grams, but mostly typically we have 5-gram vials. So we always want to round to that nearest 5 grams, because otherwise we could potentially be wasting a lot of product. If we were to say, okay, give 65.5 grams, there's a possibility that 4.5 grams out of a 5-gram vial would go to waste. And that's not being an appropriate steward of the product. We want to make sure we're using it appropriately. So we always round to the nearest 5. So again, the dosing weight calculator is used for most patients, most adult patients. You do have to meet a couple certain criteria. Your height has to be within 100 or between 153 and 241 centimeters. So most adults do fit within that category. And your weight has to be between 20 kilograms and 400 kilograms. So again, most adults are going to fit in that. Actual body weight is used in some circumstances. So as I said, this calculator is only used for patients who are considered overweight or obese. So if you're actually considered to be under your ideal body weight, we're going to use your actual body weight to calculate. Another sometimes not so common occurrence is we will be giving IVIG during pregnancy. In that case, the adjusted body weight calculator is not necessarily appropriate to use either. So if you ever do see an order set ordered for a pregnant person, we just contact the TMP through switchboard in RUH and just see what we should consider as to be the safest for that patient. For nursing considerations, we are asking that every patient be weighed prior to the first dose of their cycles. So if this patient is coming in and they are getting IVIG over the next 3 days, if you could just weigh the patient on day 1, we just want to keep track of that patient's weight and see if there's been any fluctuation that may potentially change their dose. So if there has been a weight change of 5 kilograms or more from the order, from what's written on the order set, whether that's 5 kilograms up or down, contact the MRP for a dose review. Occasionally that change won't result in a dosage change. Occasionally it will. Also, if you can also notify us that there's been a weight change as well, so we can keep track of that and make sure that we're dosing appropriately on the next order set. So back to the order set again, page 3, patient identifiers up at the top. Under monitoring here, we're following local policy and procedure. So whatever your local policy is and procedure is currently, we are again working on a provincial procedure. We don't have a launch date for that. So until that time, please just follow your local policy and procedure. Infusion rates. If a patient has had a previous reaction to IVIG, occasionally they will order the IVIG to be decreased, the rate of infusion to be decreased. The maximum rate is 4 mils per kilogram, but if they've had a reaction previously, sometimes they will decrease that. The only thing we want you to be quite aware of is if the physician does in fact decrease the infusion rate, we can only have a bottle of IVIG spiked for 4 hours. So if it's quite a large vial of IVIG and we're decreasing the rate to say half of what it normally would be, we may not have time to give that whole vial in 4 hours. So in cases such as that, nursing staff has to be in contact with the labs to see if we can maybe change the vial sizes. So instead of maybe infusing 30-gram vials, we get 10-gram vials, or 20 and 10. Hopefully we can work around getting some smaller vial sizes so we can infuse it over a longer time, but still maintain the safety of that product. IV fluids, D5W is the IV fluid of choice. Occasionally they'll ask that we initiate IV at 30 mils per hour, especially if patients have had previous reactions such as a headache. Next up is the pre-medication section. So again, if a patient has had a previous history of a transfusion reaction from IVIG, occasionally we will give them something like Tylenol, hydrocortisone, any antihistamines, or anything else such as Benadryl. That's why we do need to know if a patient has had a previous reaction, but we only like to order these pre-medications if they have in fact had a reaction. If we give pre-medications to every patient, we may be masking potential IVIG reactions that we would like to be aware of. Even if it's something as simple as a headache, we would like to know that that's happening, especially if it turns out that there's something with a lot number that maybe we needed to be aware of. That's why we don't like to give pre-medications if we don't have to. That being said, there is an entire section here, additional medications that are essentially your PRNs. You can still have the Tylenol, Gravol, ondansetron, everything ordered for you if there is an in the moment event. And then the big important box at the bottom of page 3 is the IG Stewardship Program Use Only box. And again, page 3, we need signed by the prescriber. But this box on the bottom of page 3 is what you really need to be looking at as the lab and the nurses providing the infusion. So we'll go through that on the next slide. So this is a bit of a misnomer. This IG Stewardship Program Use Only is a bit of a misnomer. We aren't the only ones that use it. We certainly aren't. We need lab to use it. We need lab to look at it, and we need your chairside nurses to be looking at it as well. So moving forward, this is something that we're going to change because there have been instances where people just disregard this because I don't work for the IG Stewardship Program. It's not for me. It is, in fact, for you. It's very important for you, actually. So we're going to change that on the new one. But the new one, essentially what this shows you is that we as the IG Stewardship Program have verified that this dose is appropriate for the indication. So we will check that the dose is verified. We will check if we've had to adjust the dose. We will write it in that line there, if required, dose adjusted to. Occasionally, that will just be simply if the physician has ordered the 65.5 grams, we will just write here that we're adjusting it to 65 for vial availability. We also want to have either the approved or possibly indicated with follow-up in 3 months box checked. So that essentially is that we verified the dose and we have approved the dose. So if it's approved, you're good to go. The possibly indicated with 3-month follow-up is also approved. It just means to us that we're going to contact the physician in 3 months to get them to follow up. The not approved box that you see here, you should never see it checked off. We should never be sending out IVIG orders that are not approved. So if you see not approved checked, please stop, give us a call, and find out what's going on, because you should never see it. And Melissa and I are never going to be the ones that say that something is not approved. If we have concerns or if there's something that's not adding up on the IVIG POS, we will contact the transfusion medicine physician on call. They will again have that conversation with the prescriber, and essentially the conversation between the two physicians, that's what will result in the not approved order. So it's never us, it's never Melissa and I just saying, it's Monday, I don't want to do it today. It's always, if it's not approved, it's always a very, very thorough conversation between the physicians. And we also want to make sure at the bottom here that the order set is signed either by a nurse navigator or by the TML, the transfusion medicine lab, if it's an inpatient order. So we want to see that it's signed and dated. So if you can see that the dose verified, the approval, and it's signed by somebody, then we're good to go ahead and provide this dose. If anything in that box is missing, confusing, you're not sure, you can always give us a call or an email and we will clarify what it means, or we will screen it if it hasn't in fact been screened. Occasionally, we've had orders that we have approved that we've sent forward to the infusion clinic, and then there's been changes made on that IVIG order that we're not aware of. So if that happens, we would like to be made aware. Especially, you need to make us aware of any changes that would require reapproval. So that would be a change in the total dose that's being provided or a change in the interval between cycles. So if a physician calls you at the clinic and says, I don't want to give 60 grams anymore, I'd like to give 70, or I want to give it every 2 weeks instead of every 4, you can certainly take that information, but please contact us and we will need to reapprove that order set. There's a few things that we don't necessarily need to reapprove. We would just very much like to know. So if a patient has had a reaction and you've decided to change the infusion rate, that is, again, is something that we would like to know as far as moving forward and providing or approving the next order set. Again, if they've had a reaction and we have to maybe split a dose over an extra day or two. So they used to get it over one day, but now that we're running it slower, it needs to be over two. We don't need to know that. We just like to know that information. And again, if they've had a reaction, you've called the MRP when that transfusion reaction was taking place, and they've decided to order Tylenol or whatever the case may be before each infusion. Again, we don't have to know that. We would just like to know that because it makes it a lot easier when we're looking for renewals and reapproval on maintenance orders. Page 4 of our IVIG order set as of right now is generic. It is just the same infusion rate table that goes with every single one of the order sets. It's all the exact same. So what it does is it breaks down the patient's dosing weight, or the weight that we're going to use to program the pump, and then what the initial rate should be and what the max rate should be. This is currently applicable to all 10% IVIG brands. Once we do launch the new order set, or sorry, not the new order set, the provincial procedure, we will be able to start using the brand specific lines, but for now this applies to all the line or all the IG brands and using the generic line or the brand specific line. Sorry. So that is the outpatient world of screening IVIG order. The inpatient world looks very, very similar. So inpatient order sets, they're being given as an inpatient. The reason these have to get screened by the TML in the providing hospital is because we only work Monday through Friday. So if you need to give a dose over the weekend, we won't be able to approve that. So that's why the transfusion medicine labs are approving those inpatient orders that need to be given a little bit more quickly. But the process itself is very, very similar. They're going to receive that order set, screen it against the criteria document, confirm the adjusted body weight per the calculator. We would like that the TML or the technologists also check eHealth for any previous doses of IVIG have been given. If the person has had a dose in the previous month, we suggest that they contact the transfusion medicine physician on call to be sure that we can, in fact, give another dose as quickly as that. We also want them to sign and date the IG program stewardship box and complete the if required dose adjusted to box or line if necessary. Once they've screened, approved, and signed it, we'd like them to refax the approved IVIG POS to the unit that's actually going to be administering that IVIG, as well as fax it to us. The only reason we really need it faxed to us is because we need to enter it into the patient registry to track the use of IVIG. And once the IVIG POS is signed, completed, dated, and faxed back to the administering unit, that becomes the approved official order that should be placed on the chart. The previous order is no longer official because it's not approved to be given. So this the approved order set needs to be placed on the chart. And the lab techs really do need to remember that they can call the TMP on call through switchboard at RUH at 655-1000 if they have any questions, comments, or concerns. They are all lovely people. They are very easy to talk to, so don't hesitate to call them with any concerns. So in a nutshell, inpatient orders are going to the transfusion medicine lab for approval. We are screening all the outpatient order sets. And for right now, we're going to follow local policy and procedure until we have our province-wide policy released. And we will certainly let you all know as soon as that takes place.
I'm Melissa. I'm the other nurse navigator in Northern Saskatchewan. I'm going to talk to you guys about transfusion reactions. So,
louder, Melissa.
Am I really quiet?
Yeah.
Sorry. Okay. I will try to project. So transfusion reactions, our outline for today's presentation is to talk about some transfusion reaction resources that we have on SAS Blood. I will show you on SAS Blood how to find them. There's also a bedside transfusion reaction algorithm that is super helpful if you guys wanted to have printed on your nursing station, or if you guys maintain any binders or anything like that. It is on SAS Blood. There's also acute transfusion reaction charts that we'll talk through. And then we will talk about adverse reaction and transfusion reaction reporting, including how to submit and complete the transfusion adverse event report, which I'm going to call a TAER going forward because that is a tongue twister for me. Some of the most common reactions you're going to see with IVIG include a headache, a rash or hives, and hypotension. Some less common reactions are hemolysis, nephrotoxicity, and thromboembolism. My slide won't go forward. There we go. So this is what the SAS blood transfusion manual looks like on SAS blood. My spinning circle. There we go. And it's found on SAS blood. You're going to come over here to the manual section, and it's just right in here. And so it is broken down as guidelines along with appendixes. Appendixes are where we're going to talk about the reaction algorithm, the transfusion bedside reaction algorithm, and that is where that's appendix number 8, sorry. And then appendix number 7 is the acute transfusion reaction chart, which we're also going to talk about today. So I'm just going to pop back to my PowerPoint presentation here. So table 1 is just a quick snippet from the transfusion resource manual that shows you what some minor reactions include: the skin rash, pruritus, and if it involves less than a quarter of the body, and if it's onset within 15 minutes, that's considered a minor reaction. A temperature greater than 1 degree from baseline, but less than 38, and no other symptoms within 15 minutes is also a minor reaction. Some more serious reactions that you need to be aware of include a temperature rise greater than 1 and greater than 38, hypotension, tachycardia, or shock symptoms, hypertension, dizziness, rigors, chills, sensations of cold, back and chest pain, headaches, wheezing, facial and tongue swelling, dyspnea, hypoxemia, tachycardia, heat, pain, or bleeding at the IV site, nausea and vomiting, generalized flushing, hives and a rash that covers more than 1/4 of the body. Restlessness and anxiety is also a serious transfusion reaction. Jaundice, red or brown urine, which can indicate a hemolytic reaction, or oliguria. So this is our lovely bedside transfusion, Appendix 8. I'm just going to bring it up on the screen here for you. Pop that closed. Appendix 8 is this one, and it is beautiful. It tells you what you need to do if your patient experiences any of these signs and symptoms. So you're going to stop the transfusion reaction, but you're not going to discard the blood product. You're going to maintain your IV, assess the patient's vitals, checking it every 15 minutes until stable. You're going to call TML immediately if an error has occurred with the patient ID or the component of blood product and compatibility. And you're going to notify your most responsible physician and obtain management directives. Your most responsible physician will determine if a transfusion or infusion should continue based on the patient's symptoms. So you can always guide through this lovely table for your minor symptoms. It tells you what to do, your serious symptoms, but once again, the most responsible physician will tell you what to do. There are some times when not to restart the transfusion, and the physician may order some additional labs or blood work. So once again, it's on SAS blood. It is appendix number 8, transfusion manual. Up next is the acute transfusion reaction charts. There's actually 4 of them. This is appendix 7 on SAS blood transfusion records. And it's right here. I find it's a little easier to see if I can make it bigger on the screen, so I'm just going to pop back to this. So this reaction chart is if the patient has a fever or a temperature greater than 38 and or equals more than 1 degree increase in temperature from pre-transfusion baseline. So it talks about if there's with chills or without chills. Chills or rigors occurring in the absence of an increased temperature may also classify as a febrile reaction and must be transported to the TML. So if you have a patient whose temp is not going up, but you do notice chill rigor, you do still need to complete a transfusion adverse event report form for us. So you can see this is the first one. The second transfusion reaction chart is for page 2. Urticaria, which is hives or rash or pruritus. It tells you if it's got with or without nausea, vomiting, abdominal pain, cramps and diarrhea, dyspnea, hypoxemia, chest pain, facial upper airway swelling, hoarseness, stridor, wheezing, anxiety, or a feeling of impending doom. And it literally just talks you through what you're going to do, suggested treatments and actions. It's kind of just a good reference as a need to know. The third one is for dyspnea, which is shortness of breath. It talks about with or without hypoxemia, if your stats are less than 90, or if they decrease at a rate of at least 5% from transfusion. So it tells you what you can do with or without intervention required to maintain SpO2 oxygen saturation. And it also highlights here to consider the following if there is a fever. It does tell you specifically to check the fever transfusion reaction chart. And the fourth one is for hypotension. And I will pop that up on the bigger screen here. So the hypertension is there is an adult section and a child section and then an infant section. So what they class for an infant is more than 5% drop of baseline. A child age 1 to 18 is a more than 25% drop in systolic from pre-transfusion blood pressure. And the adult, a drop in systolic blood pressure more than or equal to 30 millimeters and a systolic blood pressure less than or equal to 80. So it can be an either or situation. If you have somebody that's got a blood pressure of 160 starting and it dropped to 80, yeah, that'd be pretty bad. So you can always come here, make sure that you stop your infusion and follow the bedside transfusion algorithm for further steps. And so management of reporting of adverse transfusion reactions. So just a reminder that you can have an allergic reaction with the administration of blood components and blood products, and they can range from mild to life-threatening. Most reactions to IVIG are rate related. These reactions, such as headache, shivering, tachycardia, and blood pressure changes, will respond to a slower infusion rate. If you do slow down that infusion rate, please be aware that a vial can only be spiked for 4 hours. Some patients may require pretreatment with antihistamines, anti-inflammatories, and corticosteroids, particularly if they have a history of transfusion reaction, and you need to check the order set for these pre-medications. If you at any point suspect there is a transfusion adverse event, please fill out a TEER for all minor and serious reactions. This helps us track IVIG, it tracks the lot numbers, it helps track the reactions. On the document, if the infusion was stopped or interrupted, if it was restarted or discontinued, does need to be reported. The TAR is submitted to the transfusion medicine laboratory. And even if you notice a delayed reaction, so you have a patient who has completed their IVIG and they're walking out the door and all of a sudden they have a rash, a TAR still needs to be completed for that patient. If a patient goes home and comes back into emerge and has noticed that they have a transfusion reaction, please also complete a TAR. There is no limit to the time frame to completing a TAR. So like if your infusion's been done an hour and you notice these symptoms, it still needs to be completed. So this is what the transfusion adverse event report form looks like. It is a 2-page document found on SAS Blood. Oh, it took me to the wrong page. I don't know why it didn't take me to the right page. It's also on What's Popular on SAS Blood. So if you ever want to find it fast, you can go to What's Popular. So it's 2 pages. The first page is completed by the transfusion team or whoever locates the reaction. So it just tells you the reporting facility, the name, number, and information for the patient. Important one here to note is the blood component product type, the lot numbers and the expiry dates and the volume transfused and the rate. It's number 5 on page 1. And then it talks about whatever treatment was required or what you guys did about said reaction. In bold, big red letters here, it tells you where to fax the TAR form to. So in Saskatoon, you will fax them to the lab at RUH, which is 652222, or in Regina, you will fax it to 766-4382. Smaller centers just will fax to the close lab to you, whether it be Regina or Saskatoon, whichever lab is closer to your Regina or Saskatoon lab is closer to your designation. Part 8 is to be completed by the transfusion physician, and the report will be put on SAS Blood, and that's where we will find guideline or recommendations based on what happened with the transfusion reaction. And there is never an issue of completing this too often. If you think you have any kind of suspected reaction, it's better to over-report than under-report. That's the one thing we would like to highlight the most, as we are often finding that patients are getting pre-medication and we're like, well, there's no documented reaction. And they're like, oh, well, they're like, okay, well, please document. That way, all of the proper avenues can be followed. Okay, so we have a bunch of patient education on SAS blood. I'm going to take you guys on a quick tour of SAS blood just because I know that it's a little bit complicated and sometimes hard to navigate and a little bit confusing to find. So we will come here to SAS blood. And I brought it to the IG Stewardship homepage. So IVIG resources, if you ever are curious and want to see the criteria document is found here. So it's right here, criteria for use. There's aids in how to divide doses on here for you. There's all the different kinds of memos, and anytime you make a poster or anything like that, you can find a copy of it on SAS blood. We have some process maps on here for inpatient and outpatient order sets. If you are confused as to who approves it or what happens with the screening, you can always pop on here and see there's pediatric ones and adult ones. And there's also information on if an order needs changing or reapproval. We've been starting to put all of our videos and educational seminars on SAS blood. So if you have time and want to just watch us talk about more IVIG stuff, you can pop on SAS blood to see them. The link to the adjusted body weight dose calculator here. And I will like to highlight really quickly the useful links. And there is what's popular and programs. So what's popular, you'll have your body weight calculator right there. And you're also going to find that TAR form in the what's popular. And then we have a section, this is the POSs. Ooh, drew a blank there for a second. And then it's to patient resource that you can give to patients. And it tells you all about, like there's posters for RGH, there is SCIG information brochures can be found here, and there is all the documents. There's SCIG information documents found here, IV pediatric information sheet, adult information sheet. There is information on which therapy is best for patients to use. There is frequently asked questions regarding it. And on here, there is also I'm just going to show you really quick where SCIG is. Sorry, under education is where you find the patient stuff, sorry. So that's where you can find that. There's also education on here for nurses and such too. But if you come over here to blood products, it will link you to all the different blood products. So if somebody is asking about SCIG, you can pop over here and it tells you the different companies. There's 2 companies currently approved in Saskatchewan, which is Cubitrue and Hizentra. So there is information on here for both of them. And there's also the enrollment forms found on SAS blood if you have anybody asking any questions. And I think there is an IVIG infusion patient logbook. And once the new nursing procedure goes out, the IV infusion patient logbook will be required to be given to all patients getting IVIG. And that's pretty much our program. If you guys have any questions or comments, feel free to either pop them in the comments, or you can always email us at the IG Stewardship Program at saskhealthauthority.ca, or you can call either Stephanie or myself at 306-766-3135, or you can fax us at 766-3509. And I will stop sharing my screen so we can see if there's any questions. I don't see any questions or concerns in here. Oh, go ahead.
I just want to say I'm actually a patient partner that was invited by Paula to listen, and it's been amazing to watch the overview of everything and to watch the adverse reaction, how like the order sets are completed. So congratulations, like you guys have done amazing work in the stewardship program, and it's been awesome. I think the biggest thing for me personally, what I see is it and this is more specific to the TAER form. And usually the nurses that I work with are always really amazing. I think the biggest thing is more around patient education And when I'm actually coming home after an infusion, I'm not 100% sure, like some of the symptoms or some of the, is this adverse, or who should I contact? I think that would kind of be the biggest for me. And just it's not that that's a huge gap missing. It's just that those are kind of things that I think about, is if other patients are considering an adverse reaction, they contact, who's the best person
Okay.
for them to contact, because they're not always going back the next day for IVIG. They might be getting IVIG again in another few months, and they don't mention it until to their practitioners and for a few months later, right? So that's just the biggest thing I see, what I'm thinking about. But you guys have done amazing work with the stewardship program. It's flawless. My neurologist is, it's always flawless. It's a easier, and honestly, like, kudos to you guys. So good job. Thank you.
I definitely just made a note that we can look to see if there's any information on SAS blood, or if there has been a document created for patients going home for transfusion reactions. That is a very good point, actually. Thank you for bringing that up.
Hi, it's Paula.
I
There
knew you'd know the answer.
Oh, I mean, it's a requirement. It's a standard. Sorry, I guess I should take my video out. Um, um, there are documents created, so clearly, I think our job is maybe to remind the infusion clinics that they're available. I know Regina has one, and I'm sure Saskatoon has one in all the labs. So I think I'm glad you made a note. I was thinking in my head, I think we need to kind of remind everybody that they're there. And to give them, thank you, Candace, for bringing that up, because that's certainly is what it's about. You know, are you experiencing any of these symptoms? If you are experiencing these symptoms, please and usually it means go to emergency. Like, that's kind of the first step. But Dr. Harding's there. She could probably say what they should say too.
Well, I hope, Candace, that you've fallen into the between the cracks, because they know you well and they assume that you've got it all organized and that you know everything you need to know, and that an unfamiliar patient would receive that information. It's interesting to me. I can imagine them looking at you, Candace, and saying, she knows all of this stuff. I still think they should get it every time, because maybe you haven't had a reaction in years and all of a sudden you do, and you don't know what to do because you've never had to do it before. So it's something for us to follow up on, because it is an expectation that you would have all that information as you walk out the door. You've identified a potentially important gap.
That's okay. That's, other than that, that's the only thing that comes to my mind, like, just from the patient perspective. But other than that, I've seen such amazing work going into all of this, and the stewardship program. So kudos, you guys.
Thank you.
Well, I think that if that's it, we can probably call it lunchtime.
I want to just say thank you, Melissa and Stephanie, so much for doing this. And it is going to be recorded and it'll be on Sus. And thank you, Candace, for coming today. It's great to hear a patient's perspective. Okay, well, I wish everybody a great day. Thank you.